Okay, we've got
So good afternoon and welcome to the IRCnet seminar on advanced webinars and rare kidney disorders. So this is Marina Vivarelli speaking to you from Rome, and I'm truly delighted to introduce Professor Alan Salama this afternoon, who will be giving us a talk by the title, Can we avoid using corticosteroids in glomerular diseases? So Professor Salama is truly highly qualified to try to answer this difficult question. He is a consultant in nephrology and director of the UCL Department of Renal Medicine, which is rated as top in London for medicine. He specializes in immunological kidney diseases with a specific expertise in vasculitis, autoimmunity, and kidney transplantation. Professor Salama trained in Oxford and in London, and he now supervises a laboratory investigating immune-mediated kidney disease in the context of transplantation and autoimmunity. So we are really delighted to be able to have him with us this afternoon for this IRCnet webinar, and I will be trying to collect questions through the chat from all the participants for the end of his presentation. Thank you very much, Professor Salama, for being with us.
Brilliant. Thanks so much for the introduction, and thanks for the opportunity to talk to you all. I think this is a really interesting series of seminars you've got. So it's a fairly simple question, and I want you to think throughout this about your own practice. So it's going to be self-reflective, and the question is, can we or should we avoid steroids? And we're going to start off with 3 polls, and we're going to come back to these at the end. And I want you to think about these 3 clinical scenarios. The first one is a 25-year-old woman who weighs 90 kilos. This is her first presentation of minimal change disease and nephrotic syndrome. And I want you to think about what drug you would use and what dose you would start with. And these are your 5 options. Prednisolone 1 milligram per kilogram, tapering over 4 months. Prednisolone 0.5 milligram per kilogram, tapering over 6 to 8 months. Tacrolimus or another CNI for 6 to 12 months. Rituximab or methylprednisolone, 3 doses, followed by tacrolimus. Now, if you can vote on those now for us, that would be great. The poll is open, and you should be able to express your opinion. And I think we're going to give it about 30 seconds just to see. Sorry to make you all work right at the beginning of this lecture. You can't relax for 1 second. So, young woman, 90 kilos, first presentation of minimal change disease. What would you treat her with, and roughly for how long? Great.
So Alan, can you see the results, or shall I read them to you?
I can't see them.
Okay, so I'll read them to you. So 70% replied with the first, so 1 milligram per kilogram prednisolone tapering over 4 months. So that was the vast majority. Then we have 11% with the second option, 0.5 milligrams per kilogram tapering over 6 to 8 months, and another 11% with the last option, methylprednisolone 3 times followed by tacrolimus. And then we have 4% for TAC, 2 milligrams BD for 6 to 12 months, and another 4% for rituximab 1 gram twice.
Okay, great. So very good. Thank you very much. We're going to go to another question. Here we go. This keeps jumping, but here we go. So this is the second question which we're going to ask your opinions on. So this is a 60-year-old woman with lupus nephritis class 4 and 5. Her creatinine is 90 micromoles per liter. She has a UPCR of 300 milligrams per millimole. She also has arthralgias, a cutaneous rash, and some mouth ulcers. And my question is, what would you treat this 60-year-old woman with? Methylprednisolone 3 pulses, followed by 1 milligram per kilogram of prednisolone with either MMF or cyclophosphamide, 1 milligram per kilo of prednisolone with either MMF or cyclophosphamide, prednisolone, tacrolimus, and mycophenolate, or rituximab and mycophenolate mofetil. So if you can poll your opinions now. So 60-year-old woman with lupus, class 4-5, 90 micromoles per litre of her creatinine, UPCR of 300 milligrams per millimole, joint pains, rash, mouth ulcers. What would you use in this woman? Pulse of steroid followed by steroids and MMF or cyclo, oral steroids with MMF and cyclo, oral steroids, tacrolimus and MMF, or rituximab and MMF. You'll get to relax in a short while, but not just yet.
Yep, so I've got the responses for you. 69% replied again with the first option, so the vast majority. So methylprednisolone boli, 500 milligrams 3 times, followed by 1 milligram per kilogram prednisone with MMF or cyclo, followed by 18% with the second option, so essentially the same but without the IV boli. And then we have 8% with the steroid-free final option, so rituximab 1 gram twice and MMF, and 6% with the prednisolone 1 milligram per kilogram, TAC 2 milligrams BD and MMF.
Great. Okay, thank you very much. And now for the last one, if you could all have a look at this. This is the last one. Here we go. 75-year-old woman with anchor-associated vasculitis with an MPO anchor. Her creatinine is 501 micromoles per litre. She has a rash, she has some joint pains, and she has osteoporosis. And here are your 5 options. So methylpred 500, followed by prednisolone, and then either cyclophosphamide or rituximab. Prednisolone without the methylpred with cyclophosphamide or rituximab. Rituximab and cyclophosphamide and some short duration of prednisolone. Plasma exchange, methylprednisolone, prednisolone, and either cyclophosphamide or rituximab, or plasma exchange, prednisolone, and cyclophosphamide or rituximab. So if you can have a read of that and poll, decide what you want to do. So 75-year-old woman with anchor-associated vasculitis, creatinine of 501, joint pains, rash, and she has a background history of osteoporosis. What are you going to give her? This will be the last one I ask you. After this, you can relax, put your feet up, have a coffee, and then we'll come back to it later. Okay, so I think you're all still thinking, okay, that's it.
Yep, so here the response was much more spread out. So we have the most frequent response was 35% for the first option, methylprednisolone 500 milligrams 3 times, followed by pred with cyclo or rituximab. Then we have 27% of participants answering for the PEX, methylprednisolone, prednisone, and either cyclo or rituximab, followed by 20% of participants voting for rituximab 1 gram twice and cyclo with only 2 weeks of pred. And then we have 11% for the last option, PEX, pred, and either cyclo or ritux, and 7% prednisolone with either cyclo or ritux.
Okay, brilliant. So let's jump in. You can all relax a little bit now. So if we think about the glomerular diseases that we often see, we think about nephrotic states or the nephritic conditions that we deal with commonly. So things like lupus, ANCA-vasculitis, IgA, or anti-GBM disease. And depending on which part of the world you are practicing in, you might see quite a bit of immune complex glomerulonephritis, whether that's related to an infectious cause like HIV or an autoimmune disease, or even in some parts complement-related GM. If you look at the KDOQI guidelines, for all of these, steroids form a backbone of all the therapies that we have. So steroids are really the sort of building block upon which everything else is done. And in the latest iteration of the KDOQI guidelines, which came out this year, you'll see that actually there is a sort of practice point to bear in mind, which is to think about the side effects of the drugs that we're giving the patients and find the ones that minimize the side effect profile. Now, this is something new that's really been raised, and it's really important. And I want to spend the next sort of half an hour talking to you about steroids and about how we use them and what we know about how we use them. And I've shown here in this table, we'll come back to it later, but I've shown that all of them require you to use steroids. Obviously, in some cases, it's only if you have particular features. So if you've got a high risk of progression with membranous, then the suggestion is that you use a sort of modified Ponticelli type regime, or if you have a high risk of progression with IgA nephropathy. And there are some additional treatments that have been suggested, for example, with lupus or with ANCA vasculitis, which we know about. So how did we get to this point of using steroids in this way? So steroids were really identified in the 1930s, started to be used in the 1940s for rheumatoid arthritis, and were introduced into kidney disease treatments in the late 1940s and the 1950s. And different versions of steroids were used. ACTH was the first one, and then cortisone, prednisone, and then prednisolone. They're very widely prescribed. About 1% of the population in the US will be taking steroids at some stage or another, and that goes up to about 7% of all hospitalized patients. And we use them a lot in nephrology, and I think it's fair to say that we have got almost no studies looking at how they could be most effectively used. And the other thing to bear in mind is they are very effective. They have significant side effects, which we'll come to. And if you talk to patients about whether they would like steroids or not, or whether they're actually taking their steroids or not, I think you'll find a very different perception to what the physicians think would be a good thing to do. So how did we get to the current dosing regime, which we all have in the back of our mind, which is around 1 milligram per kilogram if you're an adult. If you're dealing with pediatric patients, obviously the dosing regime may be different, and it may be an alternate day sort of regime, a higher dose, but every other day. So if you look back at the history of how these studies sort of came to be, the first studies looking at steroids were really a series of anecdotal reports from different parts of the world describing the use of steroids, and the dosing regimes ranged really, really widely. The duration of treatment ranged really, really widely. This is an early study, a controlled study, looking at different forms of nephrotic syndrome, and I've picked out minimal change disease. They had a number of different conditions, including membranous. But this was just the 31 patients who had minimal change disease who were treated with prednisone versus placebo. Although when you read the paper of the controls, some of them also got treated with steroids. The dosing regime was a little bit loose. It was allowed, the physicians were allowed to decide a little bit, but in the first 3 weeks, you weren't allowed to give less than 20 milligrams a day of prednisone, and you had to treat for about 6 months. And this is the outcome from this study. If you see the graph underneath, you can two interesting things. First of all, patients who weren't treated with steroids at all had some degree of spontaneous remission, and we know that that can happen, although it took a very long time, up to 2 years, for a significant proportion of them to go into remission. And the ones treated with prednisone, not surprisingly, had a very rapid reduction in their proteinuria. This is, the graph shows a number of patients, the proportion of patients who had more than a gram per 24 hours of proteinuria. You can see a very rapid, effective reduction with the prednisone. But after these initial studies, a lot of studies were done, some studies were done in children looking at dosing regimes, but in adults, there's really not been a head-to-head comparison about timing, duration, or dosing of steroid use. And if you look at the current KDOQI guidelines for adults, the recommendation is that we go no more than 16 weeks of high-dose steroids. And the reason for having a different time period for the adults and the kids is that we know that kids respond relatively rapidly if they're going to respond, whereas the adults can take quite a bit of time. So we've extrapolated a lot of what we do for a very common adult nephrotic condition from pediatric studies, and we really haven't addressed what the best duration or tapering schedule is. And I bet you there are just under 100 of you on this webinar now. I bet you if I asked you all to say what is the regime you use to taper the steroids, I will get about 150 different answers about how to do it. Now, in proliferative nephritis, in lupus, bearing in mind that we didn't really have much treatment for these conditions, and they were often universally fatal if you had a class 3 or class 4 lupus nephritis because there wasn't any treatment. The idea of using high-dose steroids really originated from this paper in the 1960s, which looked at two historic cohorts. So it wasn't even contemporaneous. There were two cohorts that were treated either with low-dose steroids, this was prednisone 10 milligrams a day, or prednisone 40 to 60 milligrams a day for a slightly more prolonged period. And if you look at the numbers that were treated here, we had pretty small numbers, 10 and 16, not contemporaneous. And the outcomes that really persuaded people that higher doses of steroids were useful were that there were more people who died with renal failure when lower doses were used than when higher doses were used. But the outcomes were still pretty shocking. So we had 10 who died, 8 in renal failure with low dose, and we had 7 who died in the higher dose. And it's fair to say that these cohorts were not completely matched, occurring at different periods, when other things may have also been different, including the use of antibiotics and including the use of antihypertensives. So 1960s, two cohorts, slightly different outcome. It sows the seed that we should use high-dose steroids. Then comes along an idea of using pulsed intravenous methylprednisolone, very high doses. And the idea behind this was that it could actually allow you to reduce the dose of the oral steroids that were being used. So here were 7 patients treated for lupus nephritis who had methylprednisolone pulse therapy, and they suggest that not only did they do very well, they recovered, but they also were allowed to reduce their dose of daily oral steroids. This is in the 1970s. Now, later on in lupus, sticking with it, later on in lupus, there was a large study that came out of the NIH that looked at adding in second agents, antiproliferatives or cytotoxics, so cyclophosphamide or azathioprine in this group. And this is a very famous study from Austin, published in the New England Journal from the mid-1980s. And here they were looking at using prednisolone 0.5 milligram per kilogram on top of these other drugs, such as IV cyclophosphamide, azathioprine and cyclophosphamide combination, oral cyclophosphamide or oral azathioprine. Now, as a result of this study, we developed the NIH protocol for high-dose cyclophosphamide. Intermittent pulse cyclophosphamide was really established in the treatment of lupus. But steroid dosing here, at least, was a little bit lower than we used. We have somehow crept into using the intravenous methylprednisolone and the high dose of oral steroids in addition to these extra drugs that have been used without really testing whether we need to add on all these other agents. And that's true not just in lupus, it's true in vasculitis, and it's true to some extent in anti-GBM disease, and we'll come back to that. Now, I'm going to talk about ANCA vasculitis because I think it's a really good exemplar of what I'm talking about, and we will come back to talk about some of the other conditions and steroids, but I want to just use this to illustrate my points. So this is the outcome now of ANCA vasculitis. This was published 10 years ago now from combined UVAS registry data of all the patients who were in UVAS studies over the last 2 decades. And what it shows is that there's about an 11% mortality, and most of that mortality in the first year comes from infection, very little of it coming from active vasculitis. So the real desire here was to try and move away from treatments that were causing our patients to get infections, and the idea was that this was most likely due to the cyclophosphamide that was being used. And so in the late 1990s, when rituximab was introduced, the idea was that we could substitute cyclophosphamide and use rituximab, and this problem would disappear. The infection-related morbidity and mortality would disappear. So here's one of the first trials that was done. It was called the rituximab trial. It actually combined 2 doses of cyclophosphamide with rituximab because there was the anxiety about chimeric antibodies to the monoclonal, and it combined methylprednisolone and then prednisolone in both arms. And in the rituximab arm, in the bottom part, there was a steroid taper. In the top part, it was cyclophosphamide for 6 to 10 doses and then conversion to azathioprine. So first question was, is this rituximab-based regime as good as cyclophosphamide? And the answer was absolutely. Number of people who went into remission was exactly the same. Was this the saving grace for infections and mortality by avoiding or minimizing cyclophosphamide? And the answer was absolutely not. Side effect profile was exactly the same, with exactly the same proportion of patients dying and exactly the same proportion of patients having infectious complications. So minimizing cyclophosphamide did not remove the infectious problems. Then, same year, much larger study, the RAVE study, looking at rituximab without any cyclophosphamide compared to oral cyclophosphamide and then azathioprine. The endpoint here was remission and being off steroids at 6 months. And I think you all know the results of this study, which were essentially that there was no difference between the rituximab and the cyclophosphamide-based regime in terms of remission at 6 months, and there was no difference if you looked at subgroups, patients who had acute kidney injury or pulmonary hemorrhage. The side effect profile in this study was also exactly the same. So there were no benefit in terms of infectious complications. So wait a minute, now we've avoided cyclophosphamide completely, and we still have the same infectious complications and the same morbidity and mortality as when we had cyclophosphamide originally. So what is common to these studies? And I would argue that what is common is the use of high-dose steroids. In both studies, methylprednisolone pulses were mandated, and in both studies, high-dose oral steroids were used. And I will say that in the course of using methylprednisolone for a number of different glomerular diseases, you will find varying regimes, anything from 250 milligram pulses to 1 gram pulses for 3 days or for more, depending on what you're treating. So there's a very variable use of methylprednisolone. So for ANCA vasculitis, we did a small study looking at patients who had severe disease, so creatinine was more than 500, or they were on dialysis. And these were patients who, according to the MEPEC study, would have been treated with plasma exchange, but many of them also had additional methylprednisolone, sometimes because they had it in a referring hospital and then they were transferred to the treating hospital. We looked at whether the addition of methylprednisolone did anything for these patients. We found that there was no improvement in any of the parameters that we looked at, renal recovery, survival, or subsequent disease relapse. But we found an increase in the number of infections, and we found an increase in the number of patients who had new onset diabetes. So not only does adding in methylprednisolone on top of the high-dose oral steroid not benefit, it actually positively causes harm. So the first and really the only trial to look at severe nephritis in the context of analyzing steroid dosing was the PEXIVAS study that has recently been published. And this was looking at severe ANCA vasculitis where patients had a GFR of less than 50 mils or they had lung hemorrhage. And there were 2 questions. Does plasma exchange work in this group? Does that help? Or is there a benefit of reducing the steroid dose? And I should at this point say that the standard dose and the reduced dose steroids are both, in my opinion, high dose steroids. And in fact, I'll show you the data that confirms that. And the outcome of this study was either death or end-stage renal disease. And you will, I think, know the results of this study, which were that there was no difference with regards outcomes if you used a higher or a lower dose of steroids, but there was a benefit in terms of infection using lower doses of steroids. So we can use less steroid and we can still get the same benefit in terms of disease. Now, the question about plasma exchange, just while we're here, I'll mention it. There was no benefit on that combined outcome of end-stage renal disease or death. There was a little bit of a signal in elderly patients who may have had pulmonary hemorrhage, but a recent meta-analysis, which is coming out anytime now, suggests that actually, if you look at renal function as the outcome measure and dialysis independency, there is a benefit from doing plasma exchange in patients who have the more severe forms of renal failure. So if you look at the bottom table, if you have a creatinine over 500 or you're on dialysis, the number you need to treat to benefit in terms of preventing end-stage renal failure, you need to treat 6 people for 1 patient to benefit from that. The number goes up, the less severe your renal failure. So really suggesting that in patients who have severe kidney involvement, there is still a benefit of plasma exchange. We can talk about that a bit later. So let me show you what the steroid dosing regimes look like if you graph this out over the first year. So this was the original NIH protocol that combined steroids and cyclophosphamide for ANCA vasculitis. The protocol doubled the dose of steroids if patients had severe disease. And that's what it looks like. The UVAS protocols changed things over time. The Cyclops study that looked at intravenous versus oral cyclophosphamide used a slightly different regime. And here are the 2 Pexivas regimes, one in sort of dirty yellow there, which is to the right of the Cyclops, and then one in blue, which is slightly to the left of the Cyclops protocol, although it doesn't look very different. The maintenance phase looked a little bit different. So these are the UVAS. This is the daily oral steroid dosage. But if you take into account the use of the methylprednisolone that was mandated in some of these studies, I would point you to the right-hand graph, and it shows that in the NIH, you're exposed to about 8 grams in the first year. If you look at the Cyclops study, it was significantly less. It was probably just over 3. And the Pexivas high and the Pexivas low, you were exposed to just over 7 and just under 6. So significant doses of steroid when you take into account the pulses, which were actually mandated during that protocol. Now, a few people have tried looking at steroid minimization. This is a study from a few years ago looking at combining rituximab with just 2 months worth of steroids, a very small study. They did allow methylprednisolone pulses, but they took out severe disease, and they said that the relapse rates were about the same as they would have expected from RAVE, but there were fewer side effects. So possible that you could have used a shorter duration of steroids in patients who had non-severe ANCA vasculitis. We've tried a slightly different protocol, which is combining rituximab and cyclophosphamide, but really limiting steroids to 2 weeks. Now, I should say that the hardest thing about this protocol was trying to persuade colleagues that 2 weeks worth of steroids wasn't complete madness, because we're not used to using short courses of steroids in patients who have inflammatory disease. And what we found with this study is that essentially very few people required steroid introduction, even 3 years out. So if you start off with a steroid minimizing strategy in your mind, you don't actually have to put very many people on steroids when you follow them up. So 80% by 3 years were still steroid free, and you can look at the results in terms of patient survival and end-stage renal disease, very good and comparable to other conventional studies. Now, this wasn't a randomized trial. This was a cohort study, and that's a problem. But when we compared this to UVAS studies, we found fewer infectious complications with this regime, and we are desperately trying to put this through a randomized trial to get funding for it, to see if we can prove that this is a way of reducing the side effects from the therapies that we're giving. This is what that steroid minimization looks like. This is the orange line here, seeing that you have a much smaller area under the curve if you expose people to just 2 weeks of steroids, even if they have a little bit of methylprednisolone with their rituximab. There are other ways to avoid steroids. You will have seen the recent study that came out in the New England Journal using C5a receptor inhibitor called avacopan. This was used instead of oral prednisolone and had similar remission rates at 6 months. The authors went on to compare at 12 months and suggested there was a superiority of avacopan, but they had stopped the prednisolone in the control group at 6 months. So this really isn't a fair comparison, but nonetheless, at 6 months, head-to-head, avacopan equivalent to using steroids. So you can avoid steroids completely if you choose. There are now options to do so. What about in lupus? Well, there haven't been really significant studies comparing to steroid dosing, but there are two interesting findings. One is the Aurora trial, which used a new CNI called voclosporin, and mandated a very rapid tapering of steroids. And that's shown in the table on the bottom left. You can see that they started off with some intravenous for the first 2 days, and then went to oral with a pretty rapid reduction, only starting at 20 or 25 milligrams of oral prednisolone, going down by 4 months to just 2.5 milligrams of steroids. So quite a quick reduction. And what that showed is that you could do it if you had the right adjunctive therapy. You could have a very rapid steroid taper. The other study that looked at minimizing steroids was this study that came out of Imperial College in London that used rituximab and MMF, but no maintenance steroids at all, apart from 2 doses of methylprednisolone that were given with the rituximab. And their 6-month data in terms of partial and complete remission were equivalent to the ARMS study, which used high-dose steroids and mycophenolate. Their data at 1 year was slightly inferior to the study that was mainly done out of Hong Kong, and we don't know head-to-head whether, again, there would be a benefit in terms of infections or long-term outcomes. Again, hasn't been put through a randomized trial, but clearly needs to be done. So why am I going on about steroids? Well, you'll all know about the side effect profile. This is one table that shows you many of the things that steroids can do in terms of side effects. 2 things that I want to highlight that we don't really talk about very much. One is the psychiatric side effects. And there is very clear data now that this is dose related. The more steroids you give, the higher the chance of patients getting psychiatric or mental health side effects, including depression or in some cases mania. And if we have time, I'll tell you a funny story about that at the end. The other major complications that I want to talk about are the metabolic ones. And these are data coming from some of the ANCA vasculitis trials, showing that the significant proportion of people have got a weight gain of more than 10 kilos, often persists. Hypertension, about 1 in 5 people will develop hypertension, new onset diabetes, and cardiovascular disease, with an increased incidence of cardiovascular events. Now, the cardiovascular disease hasn't really been focused on in a major way. But when you look at cohorts of both lupus and vasculitis who have nephritis, cardiovascular events occur 3 to 8 times more commonly if you compare age, sex, and renal function matched control populations. Now, is this due to the disease, the inflammatory disease, or is this somehow contributed to by the therapy? The only study that really looked at addressing the therapy was a post-mortem study. And essentially what it showed is if you looked at patients with lupus who had long-term steroids or short-term, less than a year of steroids or no steroids, there were significant complications related to the steroid use. Hypertension, more fat deposition, and more coronary atheroma in those who had more than 1 year of treatment. There are studies, older studies looking at nephrotic syndromes that also suggest that in patients who are treated with steroids, there's a higher proportion who develop cardiovascular death compared to the ones who did not have steroids. This was the same study that I referred to from the early 1970s. If you look at GP databases and you look at patients who've got inflammatory diseases, not just renal diseases, but including giant cell arteritis, polymyalgia rheumatica, inflammatory bowel disease, and you look at mortality, and most of this is cardiovascular mortality, you can show that in patients who are on steroids, there is a significant increase in the mortality compared to patients not taking steroids. So that there's a 26% increase for every 5 milligrams a day, or a doubling for every extra gram of prednisolone equivalent over the first year. Now, there is a problem with these data, which is, in England we say, is this the chicken or the egg? which came first. The patients who have more inflammation tend to have more steroid need and therefore are on a higher degree of taking a higher dose of steroids. So is it the steroid or is it the inflammation? And I think it's really hard to answer this from clinical cohorts. So I just want to show you a little bit of experimental data. We've got a little bit of time that tries to address this. And what we've tried to do is develop an animal model that allows us to use steroid therapy to answer the question, does steroid contribute to the accelerated atheroma that we know happens in young women with lupus and in older patients with ANCA vasculitis and with other inflammatory renal diseases. So we took some atheroma-prone mice who have ApoE knockouts, and we gave them a high-fat diet, and then we waited a few, we gave them a nephrotoxic nephritis, which is an inflammatory model of glomerular disease, which is based on immunoglobulin deposition and then T cell and macrophage infiltration. And then we waited a couple of weeks and we gave them some treatment. And in this particular example, I'm going to show you, we gave them some steroids and we looked at their aortas 11 weeks later to look at how much atheroma there was. And the top pictures show you the ApoE knockouts with the nephritis compared to the ApoE knockouts with just saline, so no nephritis, compared to wild type animals with nephritis. So it shows you immediately that these animals are more prone to atheroma, and that is made worse by the presence of inflammatory kidney disease. And that's shown in the graph in the bottom left, where the plaque area is significantly greater in the animals with ApoE deficiency and nephritis. And if I just show you visually what happens when you give prednisolone, so the top left is the wild type, then the ApoE with saline, then the ApoE with nephritis, and in the bottom left, ApoE with nephritis and steroids. And if I show you this graphically, you can see that there is a significant increase in the amount of plaque as a result of high-dose steroids. And there is an increased mortality in this cohort of mice when you give them high-dose steroids. And that's not because they've become hyperosmolar with a high blood sugar, and it's not because they've shot their LDL up and they've caused accelerated atheroma. They've got more atheroma, and we're not completely clear why this is happening. But the introduction of steroids, and it's a high dose of steroids, does promote significantly more atheroma. So what does that mean for GN? It means that if we think that our treatments are benign, we are kidding ourselves. And actually some of the cardiovascular morbidity and mortality that we see in our patients might be positively contributed to by the treatment we're giving. And so we really have to think about whether we can avoid or use lower doses or use some tapering regime that allows us to minimize the exposure of steroids. So have we got options? The answer is, luckily, we're in an era where we have plenty of options. So if we think about nephrotic states, minimal change disease, for example, or FSGS, we know from some studies that are still ongoing, but some studies that CNIs could replace steroids. There are studies now going on looking at rituximab as a primary treatment in nephrotic states such as minimal change disease instead of steroids. What about membranous? Well, we had the Ponticelli regime that used huge doses of steroids beforehand. We now have lots of other options. Rituximab, CNIs, different sorts of B-cell depleting agents, trials now of complement, alternative factor, complement pathway blockade. There will be options. I'm not saying that these are already an equivalent at the moment, but there will be options that would allow us to minimize the amount of steroid we're using. In lupus, I think we now have data suggesting that you can use a lower dose of steroids. You can taper it more rapidly. You may even be able to use no steroid at all, although that has not been tested in the clinical trial. But we also have other B-cell depleting agents, obinutuzumab, for example. We have interferon alpha blockade now. We've got belimumab and other anti-BAFF agents, all of which could be applied in the context of not just adding on, but replacing the steroids that we're using. And that's really what I think we should be aiming to do now. Studies where we think about not adding more and more and more drugs that would the drug companies want us to use, but thinking about clever ways of minimizing the toxicities of the drugs that we're using at the moment by having these available. In ANCA vasculitis, we've got avacopan. There are some other agents that may be tested in the near future, looking at inhibiting neutrophil activation, just like avacopan does. And in IgA, whereas the prolonged 6-month dose of steroid that is popular in some parts of Europe, there are now other studies looking at BAFF and APRIL inhibitors affecting B cells, minimizing steroid side effects by giving gut-releasing steroid preparations, and other studies that are looking at complement blockade. So there are options, but the way we've been using some of these options is in addition to rather than instead of, or allowing us to reduce the dose of the steroids or tapering them more rapidly, rather than simply adding things on. Here's another question. What do we do about duration of therapy? I think anyone who does a clinic who has patients with lupus or vasculitis or other forms of inflammatory GN will have lots of patients who are on maintenance therapy for a number of years. And the truth is, we really haven't looked at how long do these patients need to be on. When you look at recommendations, these are based on cohort studies and anecdote, but no one has really looked at doing studies comparing duration of treatment. There have been a couple of studies on ANCA vasculitis, very, very small ones, considering the prevalent population we have, maybe 200 patients looked at to compare long or short durations of therapy. But we really have to balance these with the risk of infectious complications, and I think now also highlighting the risk of cardiovascular complications. And 5 milligrams of prednisolone a day, or 10 milligrams of prednisolone a day, is not completely benign, as we may have been thinking for a long time. Here's one study that looked at whether using maintenance therapy with prednisolone in patients with ANCA vasculitis is of any benefit. And the answer is, from these 3 curves, either no prednisolone, 5 milligrams, or more than 5 milligrams of prednisolone, no effect on relapse, but actually in this particular study, an increased risk of side effects. So there are alternatives that we might use. One note of caution: when cyclophosphamide was first introduced to treat vasculitis, there was this lovely abstract that came out from Anthony Fauci's group. Now so for other things, where he said infectious complications of therapy have not been observed. I think we have to test the dosing and the tapering of steroids that we're using. So I want you to come back just in a minute or two. I want you to come back and answer these 3 polls again. So let's think back again for our 25-year-old woman who is a little bit overweight, who has minimal change disease. What would you consider giving her now based on what we've said? So if you could poll now. So the polls are open. Same women, same problem, same options. This one was probably the most black and white in terms of what you all thought, quite reasonably, because you're following guidelines, which is good. So how are we doing? Okay.
Yep.
So Marie, what did we get?
So we got a slight modification. We now have, hang on a sec, because I had created, there. Sorry, I was trying to make a big window for questions, so I can't see the screen as well as I wanted to. There. Okay, sorry. Okay, now I can. So we went down to 37% of participants now opting for option 1, 1 milligrams per kilogram of prednisolone tapering over 4 months, followed by 29% opting for rituximab, 1 gram twice. And then we have 14% methylprednisolone 3 times, followed by TAC, 12%, 0.5 milligrams per kilogram prednisolone tapering over 6 to 8 months, and 8% tacrolimus 2 milligrams BD for 6 to 12 months. So there was a shift increase in the rituximab.
Yeah, okay. So let's try the second one. So this is our 60-year-old woman with lupus class 4-5. And I guess here I just want you to think about, do you need to use methylprednisolone? What do you think now? Option 1, methylpred, followed by pred, and then either MMF and cyclo. Option 2, just oral pred and MMF or cyclo. Option 3, the sort of protocol that's used in the Far East a lot, prednisolone, tacrolimus, and MMF. Or option 4, some sort of steroid-sparing rituximab and MMF. So if you can poll now, Stephanie, that would be great. Thank you. It would be more fun doing this in person with all of you there, but it is slightly strange sitting in a room somewhere with all of you sitting in a room somewhere. But anyway, at least it means we can do it, which is good. So we'll give you a tiny bit more time. Okay, there, we're done. And what have we got there?
Here we go. And I know that you're sitting by yourself in a room, but you do have 100 participants, which is a very hefty number.
But I normally like a live audience.
Yeah, we all do. It's difficult. So this time we have a pretty even division with 37% of participants answering methylprednisolone 500 milligrams 3 times, followed by 1 milligram per kilogram pred with MMF or cyclophosphamide. 31% chose the steroid-free option with rituximab 1 gram twice and MMF. 27% chose the 1 milligram per kilogram prednisolone with MMF or cyclo, and only 6% chose prednisolone 1 milligram per kilogram, TAC 2 milligrams BD, and MMF.
Okay, so last one, we're gonna be quick because you know the answers and we can get some questions. But here's our 75-year-old woman with ANCA-associated vasculitis, creatinine of 501. What are we going to give her? We're going to give her methylpred and then pred and either cyclo or rituximab, pred or cyclo and rituximab, pred with MMF. Sorry, that wasn't the right one. That was the old. So you don't have option 3 there. Sorry, that shouldn't be there. Let me just see if I can get that out. Option 3 is rituximab and cyclo with 2 weeks of pred, and option 4 and 5 are the plasma exchange with or without methylpred. So if we poll now, I have 1 minute doing that, and then we can, we're almost done. So whilst you're all thinking about that, I'm going to go to my conclusions whilst you're thinking. So I think it's fair to say that we haven't really addressed, if we introduce steroids now, we would, oh, here we go. If we introduce steroids now, we would probably not use the dosing that we are currently using. I think we would probably do a dose response of some description to figure out what the best way of using them would be. I think they have significant problems, we know about those, but I think we really have to address, given the available pharmacopoeia that we've got now, I think we should think about designing studies to really move away from using prolonged high dose steroids. And so my sort of challenge to all of you is think about it. My big bugbear is people giving methylprednisolone for no obvious reason. It's not a life-threatening pulmonary hemorrhage. You know, people have got a bit of joint pain. Normally, within 48 hours, the oral steroids will do the job. You don't necessarily need to give them big doses of pulse methylpred. Think about how you can always try and find what the lowest dose that does the trick is. So I'm sorry, Marina, what was that? What was the final poll on that one, on the third one?
So we did have an increase in the short steroid regime, because 33% of participants voted for that one, which is rituximab 1 gram twice and cyclo with 2 weeks of pred. And then followed by 26% PEX, pred, and either cyclo or ritux. 19% PEX, methylprednisolone, pred, and either cyclo or ritux. 14% the methylprednisolone boli, 500 milligrams 3 times, followed by pred with either cyclo or ritux, and 9% prednisolone with either cyclo or ritux.
Okay. So I think maybe some of you have kind of thought about, I mean, certainly even in the classic nephrotic state where steroids are the first line, and I'm not suggesting that we don't use steroids for something like minimal change, but think about whether in the right person, somebody who might be at higher risk of diabetes, somebody who might be at higher risk of complications, whether we need to do that or whether we could think about something else. And there will be more data coming out over the next couple of years for sure, but I think have it in your mind about how we might want to try and minimize those toxicities. And with that, I'm going to stop and see if there are any questions.
Thank you very much. I think that was a really comprehensive and very interesting discussion, very patient-based, which is really what we need in this context. So thank you. We already have a couple of questions. 2 questions from Dr. Enrique Morales. And his first question is, why hasn't there been another steroid-free study in lupus nephritis after rituximab?
So again, I think there is a desire to do it. There was a trial that was designed, and recruitment was very low. And the reason why recruitment was low was because there were a very large number of people who were taking long-term steroids. One of the things it showed us was that there's a huge population of lupus patients who are still on maintenance steroids who didn't necessarily have to be. So recruitment was low and the funding agency pulled the funding, and so the trial did not get completed. But it's a really good question, and I think these are not sexy trials, unfortunately, and they won't get big money, but I think they're really important for the patients. And that's been the struggle. I think a lot of trials now that get done are done by pharma-based companies that spend a lot of money on it, answering questions they want to answer, but not necessarily answering questions that we want the answers to.
Great. And also, again, Dr. Morales asks, and this is a very interesting question, at least in my opinion, do you know if there's any experience with avacopan also in lupus nephritis?
So not really been used. It's been trialed, or it's been tested or being tested in C3GN, but not being tested in lupus nephritis.
Yeah. Was another question simply about whether the answers that had been given were correct. I think, the idea was sort of to see how people changed their answers after having listened. I don't think there's a universally correct answer to any of those.
No, I think that's, yeah. It's a question of how what you do with the person in front of you. And I guess if you take nothing else away from this, I would say look at the patient in front of you and think about not what the protocol says, but think about what would be best for them, how you can adapt the treatment you're going to give them that will suit them best.
Yeah, great, thank you. And you got a thank you, excellent talk from this physician. I also wanted to ask you a question if we have just a few moments. Do you think that there are different considerations in the pediatric population compared to the adult population?
I mean, I think well, you'll know a lot more about this than I will, but I mean, I think even more important in the pediatric populations trying to avoid steroids. They've got a lifetime ahead of them of the complications, especially in conditions where it's likely that they might have flares and will be exposed to repeated doses of treatment. Really, really important to try and minimize the doses that we're using. you know, because these kids can get all sorts of problems later on. I mean, apart from the obvious, you know, growth, you know, retardation, and apart from the sort of metabolic consequences, they're going to live with what we do for the, you know, hopefully for a very long period of time, but they're going to accrue all the side effects possible. So I'm not saying we shouldn't. I just want to make it clear. I'm not saying we shouldn't use steroids at all, but far, you know, they're great drugs. But I'm saying we should learn how to use them in a better way, in a smarter way, and we should be thinking about minimizing the exposures that we have got. If it was based on a really good study that said, look, no question, using these high doses of steroids are much better than using these low doses of steroids, I would be the first person to say, well, that's what we need to do. But I don't see those studies being available, and I don't think they've really been done to tell us that that's what we should be doing. We've sort of strayed into this area in a slightly daft way, and I think we've ended up accepting that this is what we should be doing, but I don't think that's the case.
Yeah, I think one of the main fears of not using glucocorticoids is that one of their wonderful qualities is that they act very rapidly. What do you think about that? I mean, when you're thinking about different options, at least in my mind, the only drug alternatively that has been proven to be as rapidly effective is recently avacopan in the ANCA-associated vasculitis trials. With the others, especially with agents, B-cell modulating agents like rituximab or obinutuzumab, or even morbelimumab, you really have the impression that it takes a long time. Is there anything you can comment on that?
No, I think you're absolutely right, but I think the question is what you're trying to treat. So, you know, we often get it's often on a Friday evening that somebody turns up with their new diagnosis of lupus nephritis or ANCA vasculitis, and they've got some joint pains and they've got systemic, you know, symptoms. Generally, if you start oral steroids at that stage, by the time you come back on Monday morning, or I mean, you're there over the weekend, obviously, but by the time somebody else comes back on Monday morning, most of those symptoms have gone. So yes, they're fast acting, but I think, you know, in the way we've done it in transplantation, we use them for 1 or 2 weeks and then we stop them. We used to use them for ever and ever. Now that tells us that they can be very effective in that early stage where you want them to be really effective, and then pull back on them. So, you know, if you're saying, what about things that take a bit longer? That's true, but what symptoms do we have to treat that have to be treated immediately, today, tomorrow? Some of them we can use steroids for, and then the others will take time. You know, it will take 6 months for the lupus nephritis to settle down, for the proteinuria to resolve. It might even take a year. It doesn't mean we have to use steroids for a year. What it means is that the other agents that are causing the leukocytes to be depleted, for the glomeruli to be repaired, all of that takes time. The steroids are great for certain things, and they're very good, very rapid acting. But I think that's when we should start to say, let's back off on those and use something else.
Yeah, thank you. So there's a last question, and then I'm afraid we don't have enough time for more. The question comes from Dr. Bogdan Bulata, and the comment is, SLE is more aggressive in children. Is there a bigger role for methylprednisolone pulses for inducing remission?
So I think methylpred is brilliant if you need to stop something that is very dangerous straight away. So in patients who have lung hemorrhage, for example, I think methylprednisolone is great because it can switch off the cytokines and the leukocytes straight away. If you've got a really severe crescentic nephritis with a rapidly progressive GN that's occurring, and you're seeing patients with creatinines that are evolving very, very rapidly, 100%. 100%. Oh, I've done something wrong. I don't know what that is. Sorry. 100%. You can use methylprednisolone, but you know, a lot of patients with lupus nephritis will have normal kidney function. They'll have creatinines in the normal range. Not to say that their glomeruli are normal, but to say that this is going to take a long time for it to get better. We know that from all the randomized trials in lupus, anything between 6 and 12 months for your proteinuria to get better. So I would argue back that, yes, it's aggressive, but unless you've got an RPGN, or unless you've got a feature, cerebral lupus, or severe gut lupus that's causing gut ischemia, or lung hemorrhage, I don't think you necessarily need to jump in with a methylprednisolone. I think we've now got used to this, but I don't think there's any evidence that methylprednisolone adds anything in that context. I don't know the pediatric literature as well, so if there is a study that says it's of benefit, then I'm happy to be corrected, but I don't know of one that shows that.
Thank you. I think I totally agree. There are very few studies in children anyhow in this context, and I think it's very difficult because we're also scared with children of the disease not being properly controlled, and I think this drives a lot of the aggressive use of corticosteroids also because they seem to tolerate them much better. So I think that contributes to it very much. I'm going to ask one last question just because I am really curious, and then I really think we need to wrap it up. What is your impression of the prevention of relapses? That's the other moment where it's sort of sometimes difficult to pull off and taper down all the way because you're afraid that a relapse is then going to require more glucocorticoids and it's going to be worse.
Yeah, so I think there's a whole bit of work to be done about what we use as maintenance therapy, and I think what we really need to do going forward with this is figuring out who needs treatment and who doesn't. And at the moment, we don't have good biomarkers that tell us what to do. And so we end up scared of relapses in everyone, so we treat everyone even though a lot of people don't need it. Now, there are undoubtedly some people who, if we don't give them enough therapy, are going to have a very bad relapse. So I think what we should be thinking about is drug holidays for people. I think I like the term drug holiday because they might need to go back on it, and I don't think that would necessarily be a failure. But if they're off drugs for 1 year or 2 years or 3 years or 5 years, that would be of benefit. So who do we need to treat and who do we need to carry on with? And I think if you've got somebody who's had multiple relapses or somebody who's had a progressive decline in their kidney function where you can ill afford to back off, then unfortunately they're going to be in that group where you might have to use some corticosteroids as maintenance therapy. But for a lot of people, I don't think they necessarily need to have it. And I personally like to withdraw the steroids before I withdraw anything else. So they might be on some MMF monotherapy or azathioprine, but try and get them off their corticosteroids. So I think we're using it too broadly in too many people, and there are a lot of people who don't necessarily need it. But we need to be smart about how we figure out who that is.
Yeah. Okay, I think that's the perfect conclusion to a wonderful talk. Thank you so much for your time. And I'm just going to quickly go through what the next ERCnet webinars are. So the next one is on November 30th. The speaker is Giacomo Quattrocchio, and he's going to discuss IgG4 related diseases. And then after that, December 7th, Joseph Flynn on hypertension. And then December 21st, Francesco Trepiccione on monogenic forms of hypertension. So thank you very much to all the participants. And once again, thank you to Professor Salama for a wonderful talk.
Thank you very much. Bye. Have a good afternoon. Yeah.
Bye.